Okay, so first of all, what is Alzheimer's dementia? Well, Alzheimer's dementia was first diagnosed in a scientific paper in 1906. The diagnosis was actually first made in 1901, but I guess it took a long time to write papers back then. But anyhow, the diagnosis can only be made with 100% certainty through pathologic slides on autopsy of the brain. And that's how this was made. Back in the early 1900s, the practice of medicine was about following diseases, looking at diseases, and then after somebody died, trying to figure out what caused them. And Dr. Alzheimer, Alois, A-L-O-I-S, I don't know if that's important, but he was the first one to do an autopsy on a patient who developed this illness of losing memory and having fits of anger and acting crazy back then. Now, when life expectancy back in this day was, barely 65, it wasn't as prominent as it is now. As we're seeing people live older and older, we're seeing the brain being the weak link. We're correcting a lot of the heart weak link. We're correcting a lot of the kidney weak link. The lungs, we're doing a lot of things with other organ systems as medicine progresses through the years. But one area we've really not made a lot of progress on is the brain. And so what we're seeing is people are living old enough to have the brain organ be the weak link and be the factor that's causing us to become old. So as I mentioned, many different types of dementia. I'm mostly going to talk about Alzheimer's, which is characterized primarily by the autopsy brain findings. Obviously, there are things you can do to diagnose that, short of that, but it's still not 100% in diagnosis. It's characterized primarily by memory loss, and it is a result of a loss of neurons in the brain, either their function or their number. So this is a slide that just depicts a caricature of the brain. There are billions of neurons or nerve cells in the brain. And there are trillions of synapses, because each one of these nerve cells has many dendrites that branch out like tree branches and touch all these other trees. It's like a crowded forest, and they all communicate with one another. And the way our brain remembers things is the pattern of which neurons are touching which other neurons and turned on. Okay, I don't know how many of you understand binary code in computers, but it's very much the same way this works. If you have a line of parallel lines of 10 neurons, and what's the multiple of 10 different numbers you could have in sequence. There's many different ways you can connect this. So first neuron on, second neuron on, fourth neuron on, first neuron on, and these patterns are what give our memory. And that's how we remember things, and that's how we learn things. So you can imagine if you just randomly take some of these neural connections out here and there, you've lost pathways of recognized memory. So when you lose the neuron or you lose the neuron's ability to communicate to the next neuron, you have lost that pattern of excitation of the neuron that makes us feel and remember. So that's in its simplest form what dementia is. Alzheimer's dementia is primarily characterized by not only loss of neurons, but also material called amyloid that prevents the connection between the neurons. And also the nerves get tangled a bit, and we'll discuss that again in a little bit. So the 10 points of Alzheimer's dementia, that's on your handouts. I'm not really going to go into this a lot. I'd like to go more into what the physician looks at in making diagnosis. These 10 points are more things that might heighten your awareness that either you or somebody you know or love might be exhibiting some of these concerns. And it's on your desk, so I think that's an area we can skip over. You can read that over later. But it basically is memory loss, complex task difficulty, motor difficulties, confusion, loss of orientation, the things most of you understand as being dementia. So I'm going to talk a little bit here now about what will your physician, what does the medical community see as diagnosis? Because I have a lot of patients come in and have, I think, sometimes unrealistic expectations that I may be able to tell them in the first 20-minute visit whether they have Alzheimer's or not. And I hope to explain to you how or why that may not be the case. I also hear sometimes where people will say, well, I went in and we all knew she had Alzheimer's, the family all knew she had Alzheimer's, and the doctor didn't make the diagnosis for a year, or they misdiagnosed it as depression, or I hear these things. And so hopefully this will kind of help you understand a little bit what we go through in trying to make the most accurate diagnosis of the type of dementia you have, rather than just kind of knee-jerking the diagnosis. So there is no definitive test, there's no litmus test, there's no blood test, there's no x-ray test, there's not a single test that we can say that it is positive for Alzheimer's and therefore that's what you have. So that's why it's not 100%, it's a diagnosis of exclusion. There's a lot of things that can look like Alzheimer's dementia, a lot of things that can be confused for it. And so a lot of times we have to exclude those possibilities before we can conclude that this is Alzheimer's. It's a diagnosis that's probably made over time, and when we get to the time chart, I'll show you that. The further you are down the road in time, the more accurate your diagnosis is, and it can be very difficult in early stages to diagnose for sure. There's often a delay in making the diagnosis because of that. Physicians wanting to be completely certain, and families sometimes not really wanting to ask the question. We kind of do this dance a little bit. Well, do you really want to know? Do I really want to tell you? How's it going to change your life? Is there really anything different we can do about it now versus 6 months or a year from now when we tell you? So there's this kind of dialogue that goes on. And so the better you know your physician, the better the physician knows you, what your beliefs, what your values, what your morals, what your thought process is it makes it easier for us to know how to communicate with you about these things. And by all means, be very direct in asking questions. And you can be very blunt about it. What I want to know is, does my loved one have Alzheimer's disease? And that opens a dialogue and makes it much easier to give a yes/no question. And so there's often a delay in making a diagnosis. I think many physicians feel like there's not much that can be done for treatment, not much that can change it. Sometimes there can be some downsides to making an early diagnosis with insurances and other issues. And so sometimes we are just happy to be happy today and not necessarily paint a glim future for you. So open dialogue, I think, is really important in that. And the other thing in delay, of course, is like I said, sometimes you have to treat some of these other potential causes before you'll know. Yep?
2 questions.
Yep.
What's the earliest age that you've seen this be diagnosed?
Okay.
And what's the mean, the normal range?
All right. And I'll get to a slide that will go through that pretty well.
Okay.
I will tell you there are 2 types of Alzheimer's dementia.
Okay.
There is an early form of Alzheimer's dementia that will occur before the age of 60. And that is a pretty much genetic form, okay? And then there is a later form that comes on over, it's probably been going on for years, but is diagnosed over age 65 typically. And they both present the same, they both have the same pathophysiology, but one is strongly genetic and the other is not as strongly genetic, okay? So the first case ever diagnosed, I think she was 46 back in the early 1900s. So that's one of the earliest ones. 40s is very early to diagnosis.
I worry about me. It's
Okay.
about my age, thank you.
Yeah. Okay, so this is a very busy slide, but what we hold ourselves to as a medical profession is this diagnosis manual that is put out every few years. The most recent edition is the 4th edition. Soon a 5th edition will come out. And for mental illnesses, this is the Bible and the rules for what you need to have to make a diagnosis. And so we try and be very careful about being sure that this all works. So first of all, you'll see number 1 criteria. You have to have 2 of the above. Number 1 you have to have is memory loss. And memory loss can be in 2 forms. It can either be I don't remember something I learned before, or it can be I can't learn something new. And so the ability to learn something, and I encourage everybody to keep learning no matter what. Memorize a poem, learn a song, but learn and keep your mind going, because I really believe that keeping those neurons talking to one another and processing is one of the big things we can do for dementia over time. It doesn't help much once you get there, but I think it can make a big difference in prevention early on. So then you have to have that first one, which we said memory, and then you have to have at least 1 or more of the next 4, A, B, C, and D. And those are language disturbance. And then inability to do motor function, even though the motor ability is intact. An example of this is, a dementia patient who has a hip fracture, falls and has a hip fracture. They get their hip fixed, the bone's all healed, the muscles are all fine. Physical therapy says you got strength there. They won't walk again. Can't walk again or won't walk again, whatever. But loss of that motor function, even though everything is intact neurologically and muscular to work. And it's part of the ability of not being able to learn something, but it's also part of the ability of loss of motor connections that are required to carry out a motor task. The other thing is identifying objects, even though your sensory perceptions are fine. Your vision's fine, your tactile is fine, and they pick up their toothbrush one day, and they just look at it like, and you say, put the toothpaste on, and you put it on your teeth and brush it. It just isn't there. They just can't put that process together. The next thing then is complex planning, organization, sequencing, abstracting. That's probably one of the ones that's most disconcerting. But in order to plan something, you have to put a number of thought processes together. You have to remember, did I buy the groceries? Did I get the right ingredients? Where's the recipe? How many people are going to be coming? What plates do I need? There's a lot of complex planning to go on for planning a meal for guests. And so this executive function, we call it, or the ability to remember what has been done, what needs to be done, and to put that all together in an organized fashion is another one of these criteria that has to be met. And then B, on the bottom here, you see, so if you have one in the second category and you have one in the first category, it still doesn't make criteria unless that causes major dysfunction in your social or job situation. So it also has to cause significant dysfunction. If you can cover for it and move on, it isn't a big deal for you, and it's not a problem, then that still doesn't meet these criteria, okay? Then we go on to the criteria that it cannot come on sudden. It has to be a gradual onset. Things that come on very, very sudden are not Alzheimer's. There are other types of dementia or delirium, which is another thing that can happen. And then it can't be from another cause. So here's all the exclusion stuff a doctor has to do. And so we have to do a good history, have to do a physical, have to get a good family history. Is there something genetic in there? If somebody comes in and they look completely like Alzheimer's dementia, well, I failed to ask the question of what their occupation was. Come to find out they were a professional boxer for years and have been hit many times, okay? Guess what? That excludes the Alzheimer's criteria. In this criteria, you can have mixed dementias, and that's another confusing thing we'll talk about a little bit. You can have more than one cause for dementia. But anyhow, there are, and you can read them up there, all these other different potential causes for dementia that need to be excluded. If you have Parkinson's and dementia, it's probably not Alzheimer's. If you have hypothyroidism, that needs to be treated. If you have calcium or vitamin B abnormalities, those things all need to be treated first. And obviously, if you're doing drugs or alcohol to the extent that that would impair your thought process, that doesn't really count either. It has to be cleared up. Okay? And the very last one, it cannot be better explained by a different diagnosis than that axis one. Don't worry about that. But if it is better explained by depression or another mental illness, then that is the primary diagnosis. Okay? So the only reason I really want to show this to you is it's not really easy to make this diagnosis in one visit first time. There's a lot of things that have to happen in order to get a high reliability. Yes, I can go, boy, it sure looks like Alzheimer's to me. And I'd probably be right most of the time, but I don't think that's what most people want. So it is a difficult process, and it's a rigorous process to get through all this and to sort it all out. One of my attendings always said, nobody can be diagnosed with Alzheimer's until they've been treated for pseudo-dementia. What's pseudo-dementia? False dementia, which is actually depression. And that's why a lot of times I hear people say, my loved one had dementia, the doctors treat him for depression. How could they be so stupid? We know this isn't depression. But Depression looks very, very different in elderly. It can look very different in people with mild dementia. And I've had a number of people over the years that when you give them a trial of a treatment and you clear their depression, they've had miraculous recovery. And it would be sad to call this Alzheimer's for 10 years and miss that opportunity to actually treat a reversible cause. So that's why we do that, okay? Just to mention, there are some new requirements that they're looking at that might have more teeth to them based on more litmus test things, visualization of MRI patterns, spinal taps to look for amyloid and tau proteins and some markers in the spinal fluids. There's a Philadelphia compound that University of Philadelphia has come up with where they can inject this and then do a PET scan, and it'll show up amyloid in the brain. So there may be some of these tests that are coming that will give us a more definitive diagnosis. Right now, these are just research, and right now they don't change really our treatment at all. But down the road, we may be coming up with some better tests to more definitively diagnose this. So. And then after all that, then you have to say, in addition, one can exclude any patient that has these following. So anyway, enough said about that. Questions about diagnosis? Yep.
Yes, this may be a tough question for you, but basically, how common is it for a recovering stroke patient to move into Alzheimer's?
No more common than the general population. But what I will say is that it would manifest itself likely earlier, because the stroke has lost some brain function, and now the addition of the amyloid and the tangles and the combination of the two may make it show up earlier, but it wouldn't make it any more likely to get it. Does that answer your question?
Yes, sure. Thank you very much.
All right, so pathophysiology, this is the, what causes it, and we've talked a little bit about this already. So amyloid and neurofibrillary tangles, those are the pathologic sine qua non findings for Alzheimer's, and that's what makes Alzheimer's, and that's why it's different than other dementias. So pictures of brain, you'll see the atrophy on the left side, much smaller brain. These cortical gyrations are smaller. There's less brain tissue there, okay? Now that occurs to some extent in all of us as we get older. Our kidneys get smaller as we get older, our skin gets thinner, our digestive tract doesn't absorb as well. I mean, let's face it, everything gets a little worse as we get older, and so does the brain, okay? It gets smaller. Most healthy individuals are able to deal with that and not have a major issue. But if you have another insult like Alzheimer's on top of it, now you're losing even more neuronal function, and it becomes more obvious. Here's a cross-section of the hemispheres of the brain, and you see the normal side and the Alzheimer's side. So you see right away one side smaller than the other. But there's two boxes on there. The one box on the bottom is the memory, and this is called the hippocampus, and this is where a lot of the connections for memory occur in the brain. And this seems to be an area that's early on hit with Alzheimer's dementia, sometimes a little different than other dementias. So you'll see over here how much thinner the cortex is, how much less brain tissue there is in the memory section. The language section also. And this is the section where you'll see people who've had a stroke and won't be able to communicate anymore, but they process and they understand everything fine and their memory's fine and everything else. That's from a major blood vessel that's hit this area, this language area, but hasn't affected anything anywhere else. So it's a very focal finding in stroke, whereas in dementia, it's a broad, diffuse finding throughout the brain, okay? This is a picture of characterization anyway, and not an actual picture, but a characterization of the neurons, and they're all suspended here like trees, all their branches touching, talking to each other. And here would be what would look like a healthy neuron with normal branches. Here, this is static, okay? This is what's called the amyloid. It's actually a protein that has been abnormally folded and bunched up in there. And this protein adds static to the communication. Sometimes it widens the gaps between cells, prevents them from being able to communicate with each other. The other thing they're depicting here is, see how these neurons are they're not straight, and And that's what they call the neurofibrillary tangles, and I could go in why that occurs a little bit more. I was fortunate enough to be down at Oklahoma State University here a couple weeks ago, where my nephew is the head biologist down there right now, which is kind of cool. He's just a kid, but really smart kid. And he took me through his lab. He's got 2 floors of this brand new building, and they're working on all this really neat research stuff. And one thing they're working on right now is, why do proteins fold abnormally? And that's this whole amyloid question and the whole dementia question. And it's amazing the amount of research and work they're putting into that right now, but hopefully they'll be able to figure that out sometime. They already figured out hepatitis C virus treatment. That was one of their projects a couple of years ago they were working on, so that was cool. Anyhow, this is a microscope slide of the brain, and this again depicts the amyloid, which is these pink areas. And it's gelatin in the brain. It doesn't have any nerves in it, and it's just taking up space, and it's making communication hard. These are the nerve cells, and you'll see a lot of these empty vacuoles that don't have nerve cells in them. So this shows you lose some neurons, the actual cells are gone, and you also develop material in the brain that prevents the neurons from communicating well, which is abnormally folded proteins that your own cells are producing. And they're trying to find out why. The other reason Alzheimer's occurs is what's called tau proteins. And the best way I can describe this is if you laid a bundle of fiber optics out, or you laid a bundle of electrical wires out, they would all run parallel in this bundle. What makes them run parallel in our brains is this tau protein, is little tiny bridges that hold all those electrical fibers together running in the same direction. These proteins become abnormal, and they no longer are able to hold those fibers together anymore. So the bundles get tangled, and they don't run nice and parallel anymore. And when you tangle and shorten that bundle, where it's supposed to communicate on the end isn't touching anymore, and so you get these tangled nerves. So we understand a lot about what is happening. We just don't understand why or how to change it yet. Anybody know what this is? Guesses? It's not a great slide, it's a little blurry. Those are the blood vessels of the brain. Lots of blood vessels, 10,000 miles of blood vessels in the brain, arteries. And the reason I bring this up is because what we're just now learning is that dementia in general, and probably a large part Alzheimer's dementia, has a very strong vascular component to it. And there's so many blood vessels. If you block one of these big blood vessels off, you're going to have a stroke. But if you just block a whole bunch of these little tiny ones, just the very end branches, and you just sort of block those up over years, you're going to lose neurons and brain function. And what I see a lot of in my practice is vascular dementia. And vascular dementia is all about vascular risk factors: smoking, tobacco, cholesterol, diabetes, obesity, all those things that we know we can prevent heart disease with and we can prevent stroke with. We also can prevent Alzheimer's disease with if we start and we're good about these things early. Controlling hypertension is probably one of the big ones. The reason I bring this up is, even though we can't do something about Alzheimer's, and that was a great question you had, if we can prevent the vascular damage and keep the brain as healthy as we can, the bad effects that come from the Alzheimer's, we might be able to kick down the road a little further. Okay? So I'm a real biggie about treating risk factors for vascular disease. And I hear people, and I want to get their cholesterols down, and they say, well, I heard cholesterol makes memory loss. I don't want to lose my memory. Okay? Well, that's a really catch-22 here, because guess what? Cholesterol medicine prevents your memory loss too. It's a different issue. Medicines all have potential side effects, and one potential side effect of some of the cholesterol medicines can be decreased memory. But that's a short-term side effect of the medicine. If you have that and you try it, well, okay, we stop the medicine or find something different, your memory comes back. It's not a permanent memory loss. But by being good about treating your high blood pressure, your cholesterol, your diabetes, not smoking, we can actually prevent dementia, okay? Or at least stall it. I'm going to skip through this. I'm running a little short. This is one I think a lot of people want to know. I put this slide up to give us an idea about the clinical course of dementia. And we're getting kind of short on time. I'm not going to get through all this. But This is a functional assessment, and this gives you an idea about the clinical progression of Alzheimer's. And I want to spend a little bit of time with this because here we're seeing symptoms that occur, and this is almost like clockwork. It may not be at the exact time frame, but it follows this pattern where you go from your first 50 years, people with Alzheimer's and people without Alzheimer's all look the same. Your first 50 years are fine, okay? Then over the next 15 years, you maybe have some subjective difficulties. You forget words every now and then or something, but it really doesn't affect too much and nobody really notices and you just laugh it off as getting older. Then you get where, you know, your job demands. You're just not as productive as you used to be at your job. You make mistakes more easily, you know. It's just harder for you to do your job. Now it's become a little more obvious, but even normal aging individuals between 65 and 75 may have some decreased job performance and just aren't quite as sharp at getting things done as they used to be. So it's still hard to sort it out in this time frame. Now when we get down to this mild disease, and we generally divide it into mild, moderate, and severe, and then an early phase. So the first early phase can last for 20 years. Then you get into the mild phase here. Now the complex tasks, you know, making mistakes balancing your checkbook, not being able to figure out your taxes, not being, you know, making mistakes on the dinner, plans for guests, and not being able to plan for things that are happening. Those kind of things start becoming more obvious. And this is the phase when we're really able to make the diagnosis most early. But oftentimes we get in further down into the moderate before we're actually confirm the diagnosis. This is where simple tasks can be difficult, you know. People are wearing a winter coat in August. Well, that may not be so weird around here, I guess, but let's say they're wearing a tank top in January. That may be more, but this stuff is all regional, isn't it? So, and so then we get down, they're dressing improperly, putting shoes on wrong, you know, putting shirts on backwards or inside out, and then they get to the point where they can't go through the task of bathing even, you know, they'll have the shampoo, and they'll look at that shampoo bottle and say, what do? They just can't get their hair washed even. They just aren't able to do it themselves. They need constant cueing, they need constant help with it. And it goes on down, mechanics of toileting, urinary incontinence, fecal incontinence, can't hold bowel or bladder anymore. So we get down to severe, which is very non-communicative, very few words. This is pretty much bed-bound, can't ambulate, can't even sit up, don't smile or show emotion much anymore, and unable to even really hold their head up as it gets most severe. So I kind of wanted to show you that time frame, that timeline. It's a long timeline, okay? Questions about any of that? All right, so we're going to try and get to treatment here quick. I know I'm running a little behind here. So we talked about treating the reversible causes. I'm going to go past that. And medications. This is one neuron talking to the next neuron, okay? So what happens is you get electrical current down this neuron, a little plus minus change through sodium channels. And it comes down here, and now there's chemicals in the end here that are going to communicate to the next neuron, and now that neuron's going to send an electrical connection down to the next one. So these chemicals in here, there's various different neurotransmitters that happen in different areas of the brain, but one that we found that's pretty common for Alzheimer's dementia is acetylcholine. Acetylcholine is a communicating memory enzyme. And acetylcholine is broken down by an enzyme, and the enzyme is called acetylcholinesterase. So anyhow, that enzyme breaks the acetylcholine down, which is the communicator. We've tried a lot of different ways to increase acetylcholine to make communication better, but the only way that seemed to really work without causing a lot of side effects is to bind that acetylcholinesterase, the enzyme that breaks down acetylcholine. So if you bind that, you prevent it from breaking down the acetylcholine, and now the acetylcholine can communicate with the other nerve better. So that's our biggest mainstay right now of treatment is Alzheimer's, is trying to increase the neurotransmitter for better communication. So if you do have that amyloid that's spreading that connection, or you got some signal loss in there, by boosting that acetylcholine, we may be able to help that some. And so those medicines are the ones you're probably most familiar with, donepezil or Aricept. The other one is the NMDA receptor antagonist. That probably helps prevent cell loss, or what we call apoptosis, or the cells that die by sodium channels. Serotonin reuptake inhibitors are the depression treatments. And not only can depression cause dementia, but but many people who have dementia also suffer from depression on top of it. Serotonin is a neurotransmitter in that synapse, and so by increasing serotonin with a serotonin reuptake inhibitor, we can increase brain communication some that way. Sometimes we use anxiety medicines for symptoms, not the best treatment. We don't like to do that a lot. Neuroleptics are another category we use, and those we use mostly for patients who are exhibiting extreme violent or destructive behaviors both to themselves or other individuals. And unfortunately, in end-stage or late-stage dementia, we see that a lot, where people get more violent, they get more angry, you just can't console them. And these medicines work very, very well for that in very low doses, and we're not giving them enough to sedate them or anything like that, but it really does calm them down a lot. So that's something we use for symptom management, but not necessarily treatment. Anybody know what this is? Okay, I'm going to digress. 1 second, I'm going to get on my soapbox, okay? I probably only have a couple minutes left, but here's my soapbox, okay? Anybody going to eat peanuts after they see this? Sure you are. Everybody will eat peanuts. So it just amazes me when an advertisement comes on TV and the FDA requires the manufacturer to be honest. We like people being honest, right? And when they come up and they say, this is a medicine that will help you if you are the right candidate. Talk to your doctor to see if it's right for you. May cause, even death. Well, guess what? Peanuts do that too. We don't not eat peanuts, do we? So you have to realize that it doesn't mean these things are going to happen. They're very rare. You have to monitor for it. You have to use the medicine in appropriate individuals. You don't just use it in everybody, but you have to put some thought towards this. So, yep.
Well, they say that almonds is great food.
Yeah, there you go. Exactly. There you go. So anyhow, that was my soapbox. I just digressed a little bit. Living with dementia. I wanted to throw this resource up here. This is a great resource. You can get it on the web or call. They will answer your questions, personal questions, anything over the phone, and they're a very, very good organization that deal with a lot of that. Genetics, we talked about that a little bit, but I think our time is about up there, so thank you very much.